Okay, I think we are all set for our second half of this morning's program. So our second session is chronic pain, bridging clinical insight and lived experience. And moderating today's panel is Rachel Summer. Rachel is a consultant with the Northeast Ohio Opioid Consortium and has been supporting our work in the past year, engaging with people with experience with chronic pain. And we have two of those wonderful individuals with us today remotely. And I'll turn it over to Rachel to introduce her panel and get started. Thanks, Rachel.
Thanks, Jody. Like Jody said, my name is Rachel Summer, and I'm representing the Northeast Ohio Opioid Consortium today, which is a hospital-based, physician-led collaborative, which is coordinated and supported by WellLink Health Alliance. And our mission is really to improve the region's response to the opioid crisis through evidence-based education, best practice sharing, and cross-sector collaboration. Also, you heard earlier, Jody spoke about the support for this work coming from the Overdose Data to Action local grant funded by the CDC and administered through the Cuyahoga County Board of Health. We are one of numerous sub-grantees, but our strategies and our focus includes looking at strengthening clinical linkages, reducing stigma, and increasing provider compassion for individuals who use substances, including opioids. So last fall, we had the opportunity to focus in a little deeper on the experiences of people who use opioids to manage chronic pain. As part of that work, we held a series of focus groups with individuals across Northeast Ohio that use opioids to manage chronic pain as part of their treatment. Some of the things we heard from our participants included struggles with navigating the pain itself, challenges such as limited access to non-opioid treatment options, long wait times, insurance barriers, the isolating impact of stigma, and other numerous burdens. However, we also heard what is possible when care is compassionate, when providers listen to their patients, validate their pain, and follow through. Those moments of dignity and trust left lasting impressions on the participants, and they serve as a powerful lesson for our clinical community. You can see our report on your table. It's a 2-page document that's stapled, and there's some really good insights and firsthand accounts from some of our participants. We're especially grateful today to be joined virtually by Tammy and Beecham, who were two of the participants in our focus group. Thank you both for being here today. They'll be sharing their insights along the way. We know it takes a lot of courage and vulnerability to be present and share, so we're grateful that you're here. Tammy and Beecham, if you want to come off mute for a moment so we can make sure we can hear you, that would be wonderful.
Yes, I can hear you. Hope everybody can hear me fine.
Yes, thank you.
Okay, thank you for having me.
Hi, I'm Tammy. Nice to meet you all.
Thank you. And I know you can't see the audience, but everyone is smiling at you. So, and seated to my left, I'm joined by an amazing panel. I'm grateful to have Dr. Jeffrey Janata, who is the Chief of Psychology at University Hospitals Medical Center, as well as Dr. David Stream, the Medical Director of the Alcohol and Drug Recovery Center at Cleveland Clinic, and last but not least, Dr. Kevin Smith, Chief of the Veterans Addiction Recovery Center at the VA of Northeast Ohio healthcare system here in Cleveland, Ohio. Thank you all for taking time and being present with us today.
Thank you, Rachel.
Thank you. Thank you.
Thank you. To start, for our clinicians, would you be willing to share a little bit more about your role and work in chronic pain? And maybe we could just go left to left, Dr. Janata.
Sure. I'm Jeff Janata. I've been working with patients in chronic pain for most of my career. For many years, we had an integrated intensive outpatient program for patients with chronic pain. It was quite successful clinically. It was not very successful financially, and so because it was very labor intensive, but we had very high rates of returning our patients to active function. And that really is ultimately the goal of any chronic pain treatment, is improved function. So since that time, after the closure of that program, then we developed a training program for physicians psychologists and physical therapists to try to use the very strategies we found so effective in intensive outpatient treatment. And we can talk about more that a little bit later.
Wonderful. Thank you.
Yep.
Hi, my name is Dr. David Stream. I'm a psychiatrist specializing in addiction, so I'm a medical doctor, and I run the Alcohol and Drug Recovery Center. So my focus is in supporting and helping individuals who are struggling with substance use disorders. And of course, in the last 20 years, I mean, the overlap between chronic pain and addiction has, really extended tremendously. So a lot of my long-term successful patients in long-term addiction recovery also do struggle with chronic pain. And as Dawn mentioned, a lot of people who do develop substance use disorders have been previously exposed to significant amounts of prescription opiates. And hopefully, we're seeing that change. And there are obviously developments in medicine and innovation to reduce the likelihood of those things happening in the future. So I do interface with our pain services at Cleveland Clinic, both our chronic pain recovery program and the other pain rehabilitation programs that we have. But my primary focus is running the Alcohol and Drug Recovery Center.
Thank you.
And my name is Dr. Kevin Smith. I'm a clinical psychologist at the VA Northeast Ohio, or the Lewis Stokes Cleveland VA. I serve as the chief of the addiction program, and so we treat alcohol, substances, and problem gambling. We have one of 2 national women's substance use treatment programs in the country, and one of 2 problem gambling treatment programs in the country for the VA. When I started in 2014 at the VA, I was invited by pain medicine to join an interdisciplinary pain medicine team as an addiction specialist. And I, along with a psychiatrist who works with me, joined this team. And what we do on that team is we work with patients who have been challenging to develop an effective treatment plan for. And these are patients that typically have both pain medicine, pain management issues, as well as addiction issues. And we did that for a couple of years. And then in 2016, it became more formalized. But I like to think in 14 that we were really sort of setting the trend that the rest of the VA was going to follow moving forward.
Thank you so much for sharing. Obviously, we have a lot of expertise on this panel, and we encourage you, as we're going through the discussion today, to document any questions that you have, because we will have a short time period for questions and answers. But to get started, I want to talk a little bit about stigma. This is something I mentioned was a priority of the work that we're doing, and understanding how that might even be the first barrier that somebody experiences to accessing or receiving pain management treatment. During our focus groups, we heard a lot from our participants about how it affected their daily lives. First of all, as just living with chronic pain, and how that can be very isolating for individuals in the society that we live in. But in addition, participants expressed experiences where they felt misunderstood or judged when they were appropriately using opioids to manage pain. And I was hoping we could actually start with Tammy and or Beecham, if you want to share a little bit about what have your experiences been with stigma, and how has that affected your treatment or your ability to access treatment, or how you've been viewed in society. Either of you can unmute and share.
Hi.
Hi.
Firstly, I'd like to say that stigma has played a major negative role in my situation, not just regarding how I'm being viewed in the society, or it's the constant thought of what people think about me, how they view my case, and how they perceive me or how I'm being judged. The fear of opening up to people, it doesn't matter if it's a healthcare professional or anyone, the fear of opening up to them and the fear of being seen, taking most of this chronic pain meds that I take, and also the fact that I feel different from other people. Situations has arose where people maybe I'm having a conversation with one or two people regarding my situation, and I feel judged for it. I feel blamed for it. I feel like people blame me for my situation, and I feel terrible about it most of the time. So I go to a place where people condemn people who take meds for chronic pain. They speak low of them, and I cannot identify myself as one with chronic pain because of the stigma that keeps hovering around me where I go.
Thank you for sharing, Tammy. And I'm very sorry that that has been your experience, because you should be able to be open and present with who you are without judgment. But thank you for sharing.
Thank you.
And Beecham, you're welcome to share if you want. Also, it's okay if you don't want to share right now. We can hear from you in a future question.
Yeah, I think for me, stigma plays a great role, in affecting treatment, especially when, you are in a society where people don't have enough information of, or the use of opioid, and people say you like, it's like a getaway, uh, um, it's like a getaway access for you, in terms of, oh, this is drug abuse. There is important to what I'm using it for, and it's not just out of medical prescription. It's within medical prescription. So there is a lot of social isolation. Sometimes you feel judged. Sometimes you feel rejected. By your peers, family, even the community, because they don't have enough information. Of what as opioid can do, in terms of treatment, especially chronic pain and stuff like that. So yeah, I think lack of understanding, made people to criticize you for who you are, but people who knows the importance of it, rather, wouldn't criticize you. So I think that's one of the problems we're facing in society today.
Thank you so much. That's an excellent point, that we have a long way to go in terms of public education and awareness on this topic. Dr. Stream, would you mind sharing a little bit about your experience as a clinician? How does stigma show up in your work, and how do we better address this both in care settings and in the broader community?
Well, I think as we demonstrated in the focus groups that were held and what we've heard from our guests, stigma is definitely not something that has been eradicated from healthcare. And it's something that, especially in large healthcare organizations, like, all of the organizations that we represent up here, I think it's a particular problem that we continue to struggle against. And when we recognize it, it's important to call it out and call it for what it is, and really try to intervene. I've experienced my share of it for sure as well. And of course, it's disappointing to hear that from people that wear badges that look like yours, or that, are supposedly, supposed to be on the same team. One point I would make is that in a previous focus group study that was actually done in Hamilton County around the Cincinnati area, they did a really nice study about 20 years ago. There's about a 200-page report that sometimes shows up online, that also held a number of focus groups. And one of the things that that study identified was the significant impact of stigma that patients and families heard, not from physicians or nurses or counselors, but the support staff from a doctor's office or a hospital clinic or a community health center. So the front desk staff, the schedulers, the drivers in some cases would sometimes say things that certainly, very shockingly kind of undermined the message that people would hear in the closed doctors or counselors' offices about the value of medication-assisted treatment of opiate use disorder, or of, the appropriateness of this medication or that medication. And it really brought home to me that everyone in the organization has to be on the same page. And just because someone is not necessarily a clinician, they can still support the mission of the organization or do a lot to undermine it with just a stray comment here or there. So that really emphasized to me the importance of talking to everybody in the organization. In a large organization like mine, I don't make decisions about who gets hired to work the front desk in my space, but it's really important for me to talk to those folks, crawl around in their head a little bit, and make sure that they're supporting the message that we have as an entire organization about the importance of supporting folks and addressing their suffering and supporting higher functioning. So that's my thought about stigma.
That's a really important point, considering the front desk and other staff may be really key gatekeepers in determining whether somebody feels comfortable proceeding past that first step. It kind of looked like, Dr. Smith, were you wanting to add in? It kind of looked like you had
A couple things at the VA, and I appreciate Dr. Stream's comments. What we've tried to do is we have what we call anti-stigma training. It's mostly for clinical and medical staff, but again, informally, we'll do that with our non-clinical or non-medical staff to make sure they're aware. And for myself, for example, there's a lot of stigma just with addiction, much less with the chronic pain. And talking with our staff, or if we get staff who rotate in, to make sure that they're aware of how we all get training at the VA in customer service, but making sure that they're not using words such as drug addict or, someone or other pejorative type terms. The other thing that we really try to use at the VA is peer specialists. We have actually a formal peer specialist positions, and we have individuals who have addiction issues, chronic pain issues, and having them work at times, or at least have conversations early on with people who are having difficulty in these areas, seems to go a long way towards reducing stigma for the people that we serve.
Amazing. Thank you for sharing. I think peer support is a really valuable team that we are doing a lot better these days with integrating into a full treatment approach, and we're grateful for them. I wanted to bring up, on an encouraging note, we did hear from participants that there were things that the clinicians they worked with did or said that were helping them to feel more comfortable in seeking treatment. Some examples of practices that improved patients' experience were things like using active and reflective listening, regular and intentional follow-up with patients, and simply treating their pain as valid. I'm curious to hear from our clinicians today how you bring that kind of approach into your practice, and what support do clinicians need to do this more. And Dr. Janata, you mentioned just a few moments ago the 4PCP program. I'm hoping you can tell us more about the creation of that program and how it equips providers to manage chronic pain more effectively, and how it addresses some of the challenges we're talking about today.
Yeah, thank you, Rachel. I think, one of the truths that we've learned in working with patients with chronic pain is that physicians get much less training in treating chronic pain than you might think. The average curriculum in the medical school is about 4 hours of training for the thing that actually brings most patients to see us. And so one of the things that we learned was that the opiate crisis, while it was important to ratchet back overuse of opiates, it also created some of the stigma that we're talking about. And physicians felt left without a toolkit, often without the tools that they needed if opiates were being sort of removed from a regulatory perspective. Physicians were struggling then with how best to treat chronic pain. And so we created a training program based on our experience, as I began to mention a little bit earlier, where we worked to help them understand what strategies were available, particularly from the neuroscience perspective. Unlike the very good presentation earlier, chronic pain is really maintained centrally, and so it follows different rules. And we tend to think of chronic pain too frequently as acute pain that's just lasted a long time, and that's really not true. It's sort of akin to the difference between sadness and depression. Sadness is a normal acute phenomenon that we all experience, but depression is a central nervous system problem, and so is chronic pain. So we have to bring a different set of tools, not based so much on blocking sensory input to the brain, but rather thinking about the brain as the processor of pain and pain experience and suffering. And part of that process is to help, in our training of physicians, we work on helping them validate the patient's pain experience, to validate their self-report, not to challenge their self-report of pain, because that's really pretty counterproductive. What we don't want to do is sort of create an environment in which patients feel as though they have to defend their reported pain, but rather we emphasize taking pain reports at face value, validating their experience, and using that as the basis of the trusting relationship that really sits at the heart of any good medical interaction. So that's the goal, one of the goals of our 4PCP program, is bringing this new sort of neuroscience-based understanding of chronic pain to physicians who are practicing in the community, along with their psychology and physical therapy partners.
Thank you. And there's more information, I believe, in the handouts about this program. If you're interested in learning more or would like to refer any of your clinical colleagues to participate, I believe it's still active.
It is. We're very fortunate. We're supported by a grant from AHRQ, Agency for Health Research and Quality. And for whatever reason, we've been spared federal cuts so far. We just got funded for our coming year, so we feel very lucky.
Thank you. And I just wanted to offer a chance to our other panelists if there's anything you wanted to add to that conversation.
If I could, in 2016, the Comprehensive Addiction Recovery Act was passed, and that mandated all VA facilities to have an interdisciplinary pain management team. And so we had already had some formulation of that when I first started in 2014, but this became more formal. And what this team basically is comprised of is pain medicine specialists, addiction specialists, rehab specialists such as physical therapy or chiropractic, peer specialists, whole health, and then mental health specialists. And basically the purpose of this was to have this interdisciplinary team that's going to be collaborative, work with the patient, the veteran, who is part of the team, having open communication. And the goal is to work with the veteran to basically manage their pain, have better functioning, and better quality of life. And again, the other underlying was to reduce the reliance on opioids as their main pain mechanism. And so at the VA, we have aqua therapy, we have biofeedback, we have a whole slew of cognitive behavioral type interventions provided by psychology service. And again, the goal of this was to reduce the reliance on opioids and to open up this expansion. And the final piece to this is we have what we call, and the name of the group is called, Empowered Relief. And it's a one-time 2-hour group that we try to get patients who come through our interdisciplinary team for the first time. And this educates them about pain psychology, educates them about cognitive behavioral therapy, and acknowledges that there's stigma, that the patients may feel stigma, but that also stigma exists across the continuum. And just by exposing them to those concepts, it helps some of the patients just to understand where we're coming from and where we're going to try to move to, and less reliance on the thought that what medication are you going to give me to deal with this pain.
Thank you for sharing. It sounds like a very comprehensive program. I want to speak a little bit about barriers to care. So we talked about stigma being a barrier, but there are some other things that were mentioned during our focus groups that had made it difficult for patients to access care. There were many things mentioned, but just some of the examples include lack of insurance coverage for non-opioid treatments. Sometimes basic things like transportation to appointments could be challenging, or simply long waits to see providers. So when somebody's in the middle of a chronic pain crisis and they're trying to get through to their primary care doctor or their pain management physician, just getting access to them could be difficult. I'm curious, going back to our guests, Beecham and Tammy, do you have any insights you'd like to share about what type of barriers you may have experienced when trying to access treatment and care for your chronic pain? And it looks like maybe we lost Tammy, but I don't know if Beecham, you feel comfortable sharing.
Yes, I think one of the barriers is transportation. To time for appointment can be delayed. That's one of the things, especially when you have to reschedule appointment after appointment. Sometimes from the healthcare provider. Sometimes from myself, I think I wouldn't take myself out of the context, because when you're trying to schedule an appointment as planned, sometimes you want to give up and be like, okay, now I can do what suits me, because of lack of time, management, because literally I know that I'm not the only one they are dealing with. They actually have a lot of patients. So sometimes you talk to your provider and where you're supposed to have an appointment and there is an emergency. So all those things attribute to, the access of treatment.
Thank you. Thank you for sharing. Tammy, I know you rejoined us. I'm not sure if you heard the question, but we were asking about barriers that you may have experienced in accessing treatment.
Apart from the stigma and the judgments I spoke about, I also had cost barrier where most like felt like treatment was very expensive, and I had a limited insurance, and I also had the I don't know how to like put it, more like mental health challenges, um, lack of integrated care due to maybe addiction, and access more like transportation access to this care was also a problem. Most times, healthcare provider misinformation. Um, I've had a doctor refuse to, even give me a little bit of information. I mean, that's the part where I felt like they see me as the cause of my problem, and most times not really understanding the choice of words, addiction being chosen by most of those professionals can also be a barrier, and that's it.
Thank you so much, Tammy. You've really illustrated how complex the issue is, and it can be starting as simple as just trying to get to your appointments and navigating cancellations, compounded by multiple conditions that need treatment and support. And so I'm curious to our clinicians and providers on the panel, what are the most pressing barriers you've experienced or observed in your practice, and how have you navigated them, or what ideas do you have that we can better navigate those? Anyone feel free to.
Well, I can say that I think one of the biggest barriers, which are that our guests have also mentioned, is addressed by the availability and permissibility of virtual visits. That is something that in the last 2 years we've gone through at least two minor crises or near crises in the healthcare system, where mostly the federal government has moved towards eliminating the permissibility of virtual visits in prescribing, whether it be opiates or other controlled substances. And obviously transportation then becomes a major barrier when virtual visits are not an option. So I would encourage everyone, listening to this, if there's one thing that you could do to reduce barriers and keep barriers low to healthcare in general, it's making sure that the public's position on the permissibility and the billability of virtual visits continues. It's clearly something that is very popular, but I really think some administrators in different levels of government, bureaucrats, lawmakers, and also payers, they're not going to stop trying to shut that avenue of healthcare down. And they've tried to do it twice. They've had to back down, mostly because of public outcry. And I think it's important that that the public's going to have to retain and maintain vigilance to make sure that virtual visits continue to be available to everyone.
Now, just echoing that, I would say 80% of our patients want to be seen virtually. It's just a lot easier. You don't have to, if you come down to any of us at main campuses, it might take you an hour to get there. It might take you half an hour to wait. You might have an appointment that's delayed a bit. You go home, you've taken half a day, where a virtual appointment can take place in the 45 minutes or half hour or hour that it's scheduled. And as Dr. Stream said, this legislation permitting telehealth is set to expire at the end of September. And so I would agree completely that it is, because it is so well liked, mostly by patients, actually. I think we're equivocal about it. I think I often would prefer to see somebody in person. I think I'd get more out of that. But our patients really prefer it because of its access and because of what it does to it for us and for them. So I would echo what you said entirely. Write your congressperson.
Thank you.
And I would just say at the VA, and again, I agree with both of my colleagues here, we really rely heavily on telehealth in the VA, despite what you might hear in the news or in other sites. And again, it is patient access. We, especially in the addiction program and with chronic pain, we have a lot of our veterans who are unemployed and have housing concerns, food instability, and other social needs. And so what we try to do at the VA, in addition to expanding telehealth when we can, is to bulk appointments to make sure that the appointments for, like, say, mental health, and then maybe they have some type of ancillary therapy, and then they're meeting with the pain interdisciplinary team. They're all set up within a reasonable amount of time in the same day. And then again, the other thing we try to do is more social needs access. So voluntary services helps with food instability, and we have a whole housing continuum of services that helps with finding apartments or finding a better apartment or a safer neighborhood. So those are the things that we try to do. But I agree that really the most important thing is that we continue to be able to offer telehealth services so that we continue to have sustained and even increased access to our services.
Thank you. And that reminds me, I wanted to mention that we do have a monthly newsletter, the Opioid Consortium Chronicle, that comes out, and my colleague Jody puts that together, and there's always a policy update in there. So if you're like me and really bad on tracking things like that, it's helpful to have as a little reminder and what's happening at the state and federal level, and can be that encouragement to remind you to call your politicians and advocate on this issue. And I believe there may be something in our handouts that tells you where you can sign up for that, but if you go to our website. Yeah, in the program. Awesome. So if you haven't signed up, please consider doing that or sharing that with a colleague. We've talked several times about the comprehensive approach to chronic pain management in our discussion today. This was something that also came up in our focus groups. So our participants have mentioned that there were a variety of tools and techniques that they used to help manage their pain, such as diet, exercise, massage therapy, mindfulness, and there's truly many others. We've heard examples from our panelists today. I'd like to hear first a little bit from Beecham and Tammy. Do you want to share a little bit about what techniques, in addition to opioids, have been most helpful to you in managing your pain?
Yeah, I think, like you just mentioned, exercise, it's one of the things that, a lot, especially in the morning, you try to ease off, I think, you know, some pain and managing the situation, mildly. And you talked about diets, but diet is quite expensive. Staying on diet is something that it costs. The cost alone is also it's overwhelming. I think for me, basically, from my experiences, basically exercise. Going for therapy. Therapy session. Trying to stay balance, trying to not, get anxiety because of my pain or depression, anything that will, make me feel a little comfortable. And I think one thing I try, recently is, which my, therapist introduced to me was, dancing, kind of, early morning where you have to shake your body, just mildly. Yeah, it might feel weird, but I think it kind of helped because feel a sense of relief, bit by bit, So yeah, I think that's kind of technique I've been applying these days.
Thank you. I imagine that's good for the body and mind and soul.
Well, it's interesting. Chronic pain is maintained in the motor cortex in the brain, not the sensory cortex. And so the idea of behavioral activation in whatever form, exercise, movement, getting out and doing things, engaging in activities, replicates what our neurosurgeons do when they use motor cortex stimulators. So if our patients, one of our goals really is to get our patients to be more active, as Beecham said, and early morning exercise is certainly one of those. But if you can dance, that makes it even more fun.
Thanks for sharing the insights on that. Tammy, it looks like you were about to speak as well.
Usually I've used physical therapy, strengthening my muscles, because it reduces the stiffness I had, massage, exercises. So most of this don't come free, but the ability to make it consistent due to the costs becomes a problem. And sometimes even when the cost isn't involved, it can be difficult to keep up with something most times, especially when you see it as a task. So what I tried in like the massage therapy, I also tried the mindfulness and meditation that helps to relieve the stresses, the pain, and then take away my thoughts or something else, thoughts distraction.
Thank you for sharing. And I think it is important not to forget that those techniques and those other opportunities can be cost prohibitive sometimes, but there are a wide range of things that we can do, some that may be free or more attainable. But that doesn't mean we should stop trying to advocate for insurance coverage and other types of resources that will help to allow patients to utilize the wide range of treatment options. Is there anything else our panelists would like to mention about the comprehensive approach to pain management? I know we heard a bit from Dr. Smith, but is there anything else we'd like to add to the conversation?
Well, we think of chronic pain as being maintained by a number of different factors, and so because of the multiple issues that it represents, it stands to reason that bringing a variety of specialists to bear to try to be helpful is our most effective strategy. Chronic pain's tough, and it is, as I say, maintained by complex factors. So if we can bring medicine and psychology and physical therapy and exercise, physiology and pharmacy all to bear, if we each can hit 10 or 20% of the totality of chronic pain, then we have provided our patients with much more likelihood of recovery and doing well.
Thank you. I know we want to save some time for audience questions. Is there any, and I know we could talk for days about this topic and there's so much expertise in the room, but is there any final thoughts you want to leave with our audience before we move to questions about what we can do to continue this work to improve both the patient and provider's experience in managing chronic pain? We've heard some examples about where we can advocate at the legislative level, but any like key things you want to leave with our audience today?
Well, just from my perspective, I think that the biggest issue, a big issue with access is that we don't have enough practitioners who specialize in chronic pain. We just don't. The specialists are overwhelmed, and the internists often, and family medicine practitioners often feel as though they're a bit ill prepared to treat chronic pain effectively. There have been a number of different advances in apps, actually. The Curable app, for example, is one that a lot of our patients have found very helpful. If they don't have access to the full range of service, if they don't have a pain psychologist available or a physical therapist who specializes in chronic pain, and that's kind of a different breed than many other physical therapists, then having apps brings expertise to bear in an interactive way that they otherwise might not have available to them in their community. Been working with a group in Montana, and I will tell you that it is a low dense state and an awful lot of people in pain who don't have access to the kind of treatment that we're describing. So anything that we can do to create to capitalize on AI, to capitalize on apps that can be on our phones or watches, I think can be very helpful in bridging the gap between what we know patients best benefit from and what they actually have access to.